Good evening, students. I'm going to present the topic endoscopic ear surgery, which has gained popularity in the recent years. And I'll introduce you, tell you the basic points, how you are going to start, how you are going to choose it, the pitfalls, and the important points, how to start this surgery. First, few terms. Autoendoscopy means use of rigid endoscope for visualization of outer ear, middle ear, mastoid, or lateral skull base. Endoscopic ear surgery, it involves the use of endoscope beside visualization, the dissection of the outer middle ear and the mastoid. This applies to whether it is to transcanal, transmeatal, transmastoid, or transcranial lateral skull base. Then one more recent term is the transcanal endoscopic ear surgery, in which totally the surgery is done through the ear, external aortic canal. Now, in the recent year, the endoscopic ear surgery has gained popularity, and it has become the standard practice in otology center around world as adjunct to conventional microscopic surgery. And it is the sole tool for limited disease. And because of the increased popularity, the lot of researchers and clinicians have come. What researchers have done, they have refined the instrument. They have, because of the refinement of the instrument, and the clinicians have increased the knowledge and technique for endoscopic ear surgery. So increased popularity in the recent years is due to the technical advancement, growing expertise in handling of endoscopes, improvement in the instruments, technique, and knowledge. Now, little bit basic anatomy. This is the middle ear structures. You are seeing on your left side. I'll just point out. This is the middle ear structure. Why endoscopic ear surgery is considered difficult? This is the working area of your middle ear, which is approximately 81 square millimeter. One. Second, these are the vital structure: malleus, incus, stapes, all ossicles, facial nerve, tensor tympani tendon. They are all crowded together. Now, above downward, the middle ear dimension is 15 millimeter. Superiorly, in epitympanum 6 millimeter, at the umbo 2 millimeter, and at the hypotympanum 4 millimeter margin. You can see the pictures. This is an endoscopic picture. See how clear this is. This is the mallear hander. Short process of malleus. This is incus, incudostapedial joint, stapedius tendon, pyramid. This is the tympanic part of the facial nerve, tensor tympani canal for tensor tympani. This is the eustachian tube area. This is hypotympanic ear cells. This is the round window. Now, what are the main advantages of endoscopic ear surgery? On the left side, this is what we see through the microscope through the ear speculum. So using the ear canal as natural conduit of the tympanic membrane, this high quality resolution and magnification first. Second, you can see the hidden areas like sinus tympani, facial recess, hypotympanum, which you can't see with that. Second, there is no incision is needed, minimal damage to the neurovascular structure, faster post-op recovery. We restore the normal middle ear anatomy and mastoid ventilation and decrease the need for drilling. This microscope versus endoscopic view during middle ear surgery. The yellow beam is the path of the light. This is the microscopic view. This is narrow view, though it is three-dimensional. You can appreciate the depth, but the view is narrow. If you see the endoscope from the same canal, because the light is at the distal end, the view is wide, panoramic view, though it is two-dimensional. And you can, it is a bright light, bright area. Now see the difference. This is the microscopy picture. Right ear, with the operating microscope with full zoom, 6 mm oro speculum is used. Now the same ear you are examining with the 0-degree endoscopes, how clear you are able to see these malleus, incus, stapes, round window as compared to microscopic view. So wider view, clear view, yes, it is bidimensional. Now, what are the drawbacks of the endoscopic ear surgery? The first and the foremost is it is a one-handed surgical technique involved. But with practice, the mastery can be achieved. You know, in nasal endoscope also, we are doing surgery with the single hand. One hand you are holding the endoscope, and second hand you are holding the instrument. So you are also doing surgery with the single hand. The only difference is the space available for the instrument is little more as compared to ear. The second drawback is loss of depth perception as it is and binocular vision. But that depth perception can be achieved by introducing endoscope in and out. So lack of three-dimensional view can be overcome. Second important point is there has to be strictly bloodless field. That is important. Medical attention to hemostasis is essential. In the beginning, yes, we find difficulty with bleeding, but with practice, you keep on learning all those tricks and you will be able to achieve the hemostasis. Third, fogging and smearing of the tip of the endoscope. That also, because in the beginning, we remove the endoscope quite frequently as fogging occurs, and fogging occurs because you are not able to hold it endoscope for the long time. You touches in the canal or some area and causes fogging, and with experience that handling become okay and your hand becomes stable and that thing goes. Yes, it requires a physician training, mandatory training, and this is on the left side is the learning curve. If you see on the red, this is a microscopic learning curve, which is approximately 2 to 3 years. If you see the learning curve of the endoscope, it is little long, 5 to 6 years. But if you have a good mentor, you keep on working hard, I think same can be achieved. And what surgery you will do with the help of the endoscope, you won't be able to do with the help of the microscope. Once again, the comparison between endoscope and microscope, single-handed technique, that is a two-handed technique. Transcanal, no incision is needed. In microscope, transcanal with speculum or andoral or postoral incision. Suppose you have to work in the middle ear, you will have to come from the mastoid through the posterior tympanotomy. Resolution is high, both binocular vision, yes, in microscope binocular is maintained, endoscope is two-dimensional, but depth perception can be made out by in and out of the endoscope. Field of vision is wide as compared to the narrow field of vision with the help of the microscope. And since field of vision is wide, you can look around the corners. There are hidden areas like retrotympanum, sinus tympani, facial recess, hypotympanum, which are difficult to visualize in microscope. And one more thing, you will be able to visualize all these areas in a single view. You don't have to tilt it. While in microscope, suppose you want to see the sinus tympani, you have to tilt the microscope to that area in the posterior superiorly, then you won't be able to see the other areas. While endoscope, because the view is wider, you can see the hidden areas as well as the other areas, promontory and eustachian tube as well. Yes, we have the ability to look around corners. You can see the ventilation pathway by using the angled endoscope 30 or 45 degree, which is not at all possible with the help of the microscope. And the portal, though it is narrow, but the surgery is possible. With microscope, portal is wide, but at the same time, you are giving the incision. This is the operative room setup. Patient lie down. Surgeon sits on the right side, or some surgeons are doing in standing position. Depending upon in which you are comfortable, you can do either standing or sitting posture. In front, your HD camera is situated. On your right side is your operating microscope. This in case you have to switch over. This is must always for the beginner, and later on also, and anytime you find difficulty, you are not able to complete the surgery by endoscope through canal, you have to change over, switch over, and in that case, microscope is must. Then the scrub table, scrub nurse. This is the operating setup. About this HD camera, particularly 3-chip camera, so that visualization is very good. Now, when you are starting this endoscopy, you can start endoscopic ear surgery with the existing micro ear instrument which you are having. All those curate, radial knife, Rosen, sickle knife, micro Caesar, all those things are, you can start that procedure. So you do not require in the beginning those special instruments. But yes, as you gain the mastery and then you want to do the difficult procedure through the endoscope via the canal, then this is the instrument which will be required in future. These are the endoscopic special instrument by Panetti instrument by Italian. The advantages of these instruments is each instrument, all these instruments, they have suction with it. So when you are elevating at the same time, with you will be sucking also. When you are with knife, with curate, with everything, there is a suction channel. So, and they are quite curved. You can reach to the epitympanum or editors very easily with this instrument. So as your mastery, your technique improves, you will try to go beyond myringoplasty, then definitely these instruments will be required. And second, these Panetti instruments, the holding is very easy. Now, regarding the preparing the patient, how do you prepare the patient? This is the position of the patient. Patient lies supine with head ring. Head should be raised little bit. This shoulder should be down because from right side, suppose I'm sitting, I have to put my endoscope through this. If the shoulder is raised, that obstruct my endoscope. So this shoulder must be down. So what happens? The problem happens in an obese patient where this shoulder is little higher up. In that case, you will have to raise head little bit more up so that shoulder remains down and it doesn't obstruct your vision. Now, there are few words about potential of the thermal injury, because people say that there is chances of the injury from the tip of the endoscope. Yes, there are chances of injury, provided your light source, power of your light intensity is 100%. So this is the recommendation, that your light source should not be greater than 50%, whether it is LED or xenon light source. It should be 20, 30, 40. That light is sufficient for illumination, and it has been seen that with that much intensity, there is quality of your picture remains same. Second point, there has to be a safe distance of more than 5 millimeter from inner structures, because of in case rapid decrease in temperature within minute on switching of the endoscope or applying suction. It has been seen that if you keep the light on for a longer time, there is drying of mucosa, there is drying of chorda tympani, little bit dysfunction is possible. But provided your light is more than 100%, make sure whenever you start this procedure, the light intensity of the light should be either 20, 30, 40, not beyond that. Now, those who want to start it, there is an international working group on endoscopic ear surgeon, by which you can gain your skills in endoscopic ear surgery. They have various videos. They organize various workshops throughout the world, in India as well. You can attend those workshops and increase your knowledge. And various videos are also there, module are also there on YouTube. By that also you can learn, you can attend the workshop, you can do the temporal bone dissection, you can do the endoscopic dissection on cadaver. Now, how to select the patients for beginner when you are starting? My feeling is when you are starting, prior to starting the endoscopic surgery, you have to do endoscopic examination by the otoscopy examination with the help of the endoscope. The way you are doing DNE, nasal endoscopy, as you do, same you start 1 or 2 months before in your minor OT in OPD. Do it after the OPD when you have seen all your patient. Take your time, gently do it with suction. Everything should be available to you, not in hurry. And slowly you do. What will happen in 1 or 2 months? You will be able to fix your endoscope. Your stability will increase. One. Second, you will be able to work with your instrument. Third, you won't touch the other areas because patient feels uncomfortable when you put the endoscope in the bony meatus or you hit the bony meatus. If you remain in the cartilaginous meatus, patient will not be uncomfortable. And with changing the position, you can see the all areas that will come with your experience. You keep on doing autoendoscopy 1 or 2 months, at least 50 to 100. You do it with a 0 degree in your minor OT and then switch over for the surgery. And that too will the simplest surgery. And the simplest surgery for endoscopic ear is myringotomy or grommet insertion. So how to choose your patients when you are going to do endoscopic surgery? First, patient age should be preferably 30 to 40 years. And since it is easier to do under local anesthesia, because under general anesthesia, though patient will not move, but bleeding is much more. So you will find difficulty in doing endoscopic ear surgery under general anesthesia. So I think under local anesthesia, it has to be done when you are beginning because bleeding is little less. Preferably, patient should be 30 to 40 years. Second thing, when that patient you are going to take up for surgery, when you are doing EUM autoendoscopy for this patient, if this patient was struggling or he was not tolerating, this is not the patient under local anesthesia for endoscopic ear surgery also. If patient tolerated your autoendoscopy in your minor OT, you can go ahead with the endoscopic ear surgery in this patient. One. Second, the external aortic canal, because your instrument will go through that as well as the endoscope. If you are using 4 mm endoscope, then you have another 4 to 5 millimeter area for your instrument. If you are using 3 millimeter endoscope, then you have 6 millimeter area. So in the beginning, make sure wide external aortic canal you choose and left ear, because if you are a right-handed surgeon, it is easier to operate in the left ear because you don't have to cross over your hand. And there should not be any comorbidity. Comorbidity means no diabetes, no hypertension, no other problem, preferably when you are starting this. Now, about the surgery, once you have decided to do surgery, what are the important points? How will you proceed? So the important point when in surgery, to me, first and the foremost is local infiltration. Local infiltration is given at cartilaginous and bony junction, 3 or 4 points. And to me, that is a little difficult in the beginning. The problem is if you are not able to give it correctly, it will cause bleeding. It can cause bleph formation. And once there is bleeding or bleph formation, you won't be able to do the surgery. You will have to wait for a long time. So my feeling is local infiltration in when you are starting your endoscopic ear surgery, do give it under microscope, which is little easier. You put the speculums, little bigger speculum, in which the cartilage and bony junction become prominent, and easily you can infiltrate. Once you have infiltrated, then switch over to the endoscope. Once your mastery will be there with the help of the endoscope, you will be able to give infiltration with the endoscope as well. Always keep the microscope ready for switchover. Next important step is incision and raising the flap. This is the first and the most vital step, because this is the step in which bleeding starts, and it becomes very, very difficult when too much bleeding is there. So you have to be careful when you are raising this flap. I will tell you all the points, how to raise the flap, what are the points you have to keep in mind when I will be showing you my operative video, in which each point I will be telling you few points. I have few videos as well. Now, what are the pitfalls? Plenty of people, plenty of students start this endoscopic ear surgery, but they give up too soon. So first and the foremost, you don't have to give up too soon. Keep on working hard. Keep on trying. You will be able to do the endoscopic ear surgery 8, 10, or after 15 endoscopic ear surgery. Don't give up too soon. Yes, in the beginning, each one finds it difficult. Single-handed technique, difficult to fix the endoscope in the canal. But with practice, you will be able to do it. Regarding hemorrhage, once hemorrhage is there, bleeding is there, just use the cotton pledget. Keep it pressed for some time. Do not fiddle in the bleedy area, because when there is bleeding, you touch other areas which should not be touched, and bleeding start from those places as well. Just wait for some time. Use cotton pledget soaked in adrenaline, or use irrigation. Wait for some time, and you will be able to stop the hemorrhage. Narrow ear canal, you can't do anything. You have chosen the wrong patient. Fogged endoscope, yes. In the beginning, there will be fogging, but with practice, that fogging will go. Before taking up the patient, that one more thing, important thing is trimming of the hairs. Always, once you have given local anesthesia, then trim the hair of the extraordinary canal. That gives you about 2, 3, 4 minutes, by which the local infiltration gets distributed in the extraordinary canal. And after that, you can start the endoscopic ear surgery. But what to do when bleeding is there, or fogged endoscope is there, or you are not able to do? What is the alternative for that? And this is the alternative for all these things. To mentor, you should have a good mentor. You should have a good mentor. Not necessarily endoscopic ear surgeon, microscopic ear surgeon can also be good mentor, who believes in you, who is always standing when you are starting the surgery, who is encouraging you, and who is telling you keep on doing hard. Any problem is there, I'll take over, you don't worry, but you keep on trying it. And once you have a good mentor, you will be able to do all those surgery with time. Now, these are my videos in which I will keep on telling you how to give, what are the points you have to keep in mind. So this is the incision for tympanomeatal flap. You can see first you come out, look at that hairy area, and then approximately 5 to 8 millimeter. Press it hard. Knife should be sharp. Press it hard into the bone. Not necessarily you have to give in one go. In 2-3 go, you can give that incision 1 point. Second point, when you are going down, remember that tympanic membrane is obliquely placed. So when you are going down in lower area, you have to come closer to the floor. Third point, start raising the stop. So I went to the annulus, then start from the superior area, which is the thick skin, press it hard once or twice. That crushes the capillary, that decreases the vascularity. Pressing hard over the bone, keep on going downwards, 12 o'clock to 6 o'clock. Once you start seeing whitish bone, then your elevation will start. Knife should be sharp. Next. Raising the tympanometer. You can see that I have kept the cotton there. And once whitish bone, see the whitish bone is seen there. Now start the elevator. And this cotton is must in the anterior place because your TM flap will fold over that. If you don't keep the cotton, this TM flap will fold 2-3 times, and to bring it back will be very difficult. So always keep the cotton in front. Keep on seeing that I'm not removing the circular knife. It is at the same, and I have changed it up. Keep on changing your position of the endoscope. When you are working down, go little, take the endoscope up. When you are working up, you keep the endoscope to the floor. That's how you raise the tympanometer flap. This is the margin for myringoplasty. You can see the whitish rim. For that, you can use the needle. Don't remain close to the margin. Just remain little away from the margin. You can do multiple perforation, and then you can connect it to make freshen the margins. Just keep on seeing that. Important point in this is needle should be very, very sharp. Needle should not go deep enough to touch the promontory. When you are freshening a margin at the posterior superior area, be careful, incudostapital joint is coming at that area. So I'm seeing where the attachment is there. If any attachment is there, fibrous attachment, I'll cut it with the micro scissor. This same step you can do with the help of the sickle knife as well. Now micro scissor I will use. Next is the underscoring. The circular knife should be small enough that it goes through the perforation. It should not be big. You have to take out the mucosa from the undersurface, particularly from the anterior margin. Make it raw so that your graft can take up. All around, careful posteriorly, incudostapital joint is coming. You can see here the tympanosclerotic patch there. Annulus elevation. You have reached to the bony annulus. You just see this is the point. Make sure this is the grayish membrane. You can see there. I'm using the sickle knife. The middle ear mucosa is a little bit grayish. There should not be any bleeding. Otherwise, keep the cotton pleated there. Do not dislocate. The posteriorly, you can see the chorda tympani nerve there. Yes. Just anterior to the chorda tympani, you dislocate it. Cotton plug is anteriorly, yes. This middle ear mucosa You can cut with the frozen needle or with the sickle knife. You can see now you can use the radial knife to elevate in the lower part. You can see the incutostepidial joint there. This is the incutostepidial joint there. Now with the radial knife, quite close to the bony annulus, you can bring it down completely. Anteriorly, you will keep the cotton plate over which your tympanomeatal will fold. That is must. (12 o'clock to 6 o'clock). Same, without removing the circular knife, you rotate the knife, go up just above to see the short process of the malleus and strip off the short process of the malleus and bare the handle. You can see the round window niche there inside. And for that, just fold it with crocodile, pull it anteriorly. Lower down whitish is chorda tympani. This is right ear, which goes into the 9 o'clock position. Notch of Rivinus there. Go above. Then this thicker portion of the skin, hold it with the crocodile, pull it anteriorly. You will be able to see the short process of malleus. You can see the handle of the malleus. This is the handle of the malleus lower down. Yes, this is the handle of the malleus. And I'm trying to see the short process of malleus. After that, I will elevate from the handle of the malleus. Remain very, very close to the handle of the malleus, and you will be easily able to elevate your TM flap. Just remain very, very close. Only thing is, do not make the ossicus too much mobile. Next, little bit of anatomy. This is the long process of incus. This is the tensor tympani tendon. Tensor tympani tendon and processes cochleaformis. This is incus, incutostepidial joint, stapedius tendon, round window, chorda tympani nerve. This round window niche, promontory. And so clear view is seen with the help of the endoscope. And this view is not at all possible with the microscope in one view. We don't have to change or obliquely or here. Whole view is in one view. You want to see little close, take the endoscope little bit inside. You can see the tympanic part of the fascia nerve there, which is indicated by that. You can see the isthmus tympanic anticus as well. This is the fenestration of foot plate for you see the incus there, long process of incus. Fenestration is being done of the foot plate of the stapes. Next. This is the piston insertion for otosclerosis. This can be done later on once you get experience. Maybe after 1 or 2 years, you will be, once your hand becomes stable, you will be able to do this, all these procedure. Only thing is you have to do lot of it. This is the piston which is snugly fitting over the incus. We see with the mobility with the moving the malleus. And after that, I'm not putting gel foam. You can use ointment, antibiotic ointment, which is easier also. And gel foam is usually have infection. They are not good quality. Just from inside out, you keep on coming out. That's all. Don't touch. You can use it for laryngoplasty. You can use for stapedectomy. You can use for any mastoid surgery. Thank you. I'll be happy to answer your questions if you have any. You can ask your question in chat box.
Thank you very much, Dr. Sunil. Trainees, you may type your questions in chat box. Thank you. Welcome, Dr. Nilima.
Can we do it? See it again? I would like to show one video once again. Just go to previous video, that cotton part. No. So just put it. So what I wanted to tell you is that cotton pledget, which I have kept it here, as soon as I will remove it, the TM flap will automatically come back to its position. And then you can put the ointment over there. As soon as so once you remove that anteriorly cotton pledget, automatically TM flap will come back. And then over that you can put the ointment. So I have removed the pledget. As soon as I removed the cotton pledget, that flap came back to the normal. And just see the overriding of the edges, just smoothen those edges, and then start putting the ointment from inside out. And don't touch the ointment for 10 to 12 days. And after 12 days, we'll do the suction. Okay, any questions? Fustis.
Good evening,
Fustis
sir.
Good evening.
Sorry, I was late in joining. Something came up last minute, sir. I'm sure the talk would have been really interesting, and I missed it. Abhi, there is only one question, Abhi, as yet, sir.
Yeah.
One participant is asking, what is fustus?
Okay, just go to the middle ear anatomy. We have one diagram. Okay, so I'll show you here. Where is the marker? So fustis is the bony pointer which goes in the round window and which points towards the round window membrane. That is fustis. This is funiculus, and fustis goes towards the round window. So that tells you. The other thing for round window membrane is always perpendicular to the footplate of stapes. So always it will be close to the footplate of the stapes. In case fustis is present, that also helps you to identify it. Could you tell us? So next question is, could you tell us endoscopic anatomy? This is the endoscopic anatomy. Okay, I'll tell you once again. So this is your malleus, short process, umbo. This is the incus, incudostapedial joint. This is stapedius tendon, pyramid. This is the tympanic part of the facial nerve. This is the canal. This is the tensor tympani tendon. This is the canal for tensor tympani. And this is between tendon of tensor tympani and incus is isthmus tympanic anticus. And posterior to incus is isthmus tympanic posticus. Then this is the round window, tegment of the round window. This is funiculus. This is round window membrane. This is the hypotympanic air cells. This is the Eustachian tube. And in the floor, this is the protympanum where internal carotid artery at times, if bony dehiscence is there, you can see the pulsation. Yes, you can use the 2.7 mm, but remember one thing, if you use the 2.7 mm endoscope, your vision will not be that wide. One. Second thing, when your endoscope is smaller, the chances of injury are more. You will go and hit the bony meatus, much more common than the 4 millimeter. But if needed, 3 mm endoscope can be used. To begin with, you will start with 4 mm, and once you have little narrow canal, you switch over to 3 mm. 2.7 is little lesser. You can use gel foam. I'm not saying not to use it. You can use gel foam. We are not used to that gel foam. We were using in the beginning gel foam. What happened? Gel foam got stuck to the flap, leading to fungal infection. After that, we have stopped using the gel foam. But yes, you can use the gel foam. Rather, I feel using the gel foam, you require your hand should be very, very stable. If your hand are not stable, you put the gel foam. First thing, it is difficult to put the gel foam in the beginning. Second thing, the gel foam may disturb your TM flap and it will not approximate nicely. While it is easier to put the ointment as compared to gel foam in the beginning. Regarding the subiculum and ponticulus, subiculum, ponticulus, this is the ponticulus and this is the subiculum. And between this is sinus tympanic. Autoendoscopy, to me, the ideal autoendoscope is size is 4 mm. 4 mm, everywhere it is available. You can easily use it. To me, 2.7 mm, little dangerous. When you are beginning, sharp instrument, lesser diameter, not to use. If patient moves, you can damage the tympanic membrane. Use wider diameter, and 4 mm is correct, which gives you wider view rather than 2.7 mm. So 4 mm has to be used. Any other? Zero degree, yes, 0 degree. Always 0 degree is very easy to work on because you see the straight. 30 degree with mask, once you are trained with 0 degree, you will be able to use 30 degree. And 30 degree, we work for the ventilation route, isthmus tympanic anticus and posticus, which is a little bit difficult to look for those areas. You have to tilt it, but with 30 degree and 45 degree, you will be able to work with that. BIP is not needed. It is somebody has written BIP. No, BIP is not needed. Gel foam is okay. BIP is not needed. Very, very small tympanomeatal flap. We don't use BIP for that. You use gel foam, medicated gel foam. That's all. Any other questions?
I don't think there are any more questions, sir.
If you want, I can repeat few points, or that is okay.
Sure, sir. We have around 10 minutes, so
I will once again. One point in all in season. I will all just start our surgery. One point in all point. The surgical points I will keep on telling. Just go to those videos. Okay. So No, first in the local infiltration. So local infiltration, in the beginning, you have to give under microscope. And once you have given local infiltration, then you will use the endoscope. Now, once you have given the local infiltration, just put the cotton pledget soaked in adrenaline into the external artery canal by the time you are switching over to the endoscope. It will take 3-4 minutes. By the time there will be decongestant of the external artery canal, and after 4-5 minutes, when you are start giving an incision, there will be decreased vascularity. Now coming to your raising the flap, just go. Raising the flap, 2-3 important points. Knife should be sharp, 1 point. Second point, first see the hairs. That is the portion, and then go inside. Start from the thicker area, which is posterior superior area. Start incision from that area. Press it hard over the bone. That will crush the capillary. I am giving in one go. You don't have to go give the incision in one go, 2-3 times, and then connect it. And once you start seeing the bone, then the elevation will start. Next elevation. So raising will start once you start seeing the white bone. Prior to that, you will not raise the TM flap. See, I'm slowly. See, the movement should be controlled. It should not be too much. We don't have that much space. And once this thick skin and you start seeing, then you start raising the flap. Here you can use cotton plug also. Small cotton, and with the cotton, just push it anteriorly gently. You will be able to raise the flap. Always keep the cotton pledget anteriorly so that flap fold over it. Next. Freshening of the margin, sharp needle is needed. Multiple perforation can be done in the beginning rather than giving continuously, and connect those perforation. So needle should be sharp, multiple perforation, connect that, and then if needed, micro scissor may be needed. Don't touch the promontory. Careful when you are this posterior superiorly, you have to be careful. Next. Underscoring is very, knife should be small so that it goes through the perforation. Remove the mucosa from the undersurface, and particularly in the anterior area. Posterior area, no problem, because you are raising the flap posteriorly. You can see the Eustachian tube. Always, whenever you are doing myringoplasty, just show the Eustachian tube. You can see the Eustachian tube there. Always look at the Eustachian tube, whether it is open or not, because that is the main cause. If it is not open, you can use balloon dilatation. Next. Annulus elevation, you will not start unless there is totally bloodless field. You see there is no bleeding. If bleeding is there, you again put the cotton, wait for 2-3 minutes. You can see that whitish chorda tympani, no bleeding. You will be able to see middle ear mucosa, and then start elevating. Once you elevate, annulus will easily come. Once it comes, keep on seeing. That is a grayish mucosa. You can use needle here also, but don't take it deep, because deep is in cutoistapetal joint. And tear the mucosa with the Rosen needle, and then radial knife can be used, or sickle knife. This is the middle ear mucosa. Tearing is done. Now use the radial knife, go to the lower border. Use the radial knife close to the bone, and you will be able to raise the flap. This is the radial knife. Only thing is, movement should be controlled, should not be too much. Space is not there. It doesn't allow us to move the instrument too much, because space is approximately only 1 or 1.5 centimeter, not beyond that. And endoscope is taking about 4 millimeters space. So, and don't take out the instrument quite frequently. there with the help of thumb and index finger, rotate the mouth upward and then next one, sir. The anatomy I have already told you. Next. That's all. Thank you. What? Post-operative luxative. I don't think that is needed. I don't think. For stapedectomy, we keep the operated ear and little rest for 1 day. That's all. For myringoplasty, it is which antibiotic is preferred? Any antibiotic? We are using Neosporin. You can use any antibiotic.
So that was an excellent demonstration because in places where they don't have the teaching arm, so I think even the surgeries, myringoplasties, and I think that was an excellent demonstration how to raise the flap and how to start elevating the annulus, make the tear to see the middle ear mucosa, and even with the endoscope, you were able to show it very nicely, sir. So I'm sure the participants would have benefited a lot. And these recently, this Fustus was asked in their exam, so I think that was that is how.
Okay. But that is a difficult question.
Yeah.
Okay.
So it was part of one of the OSCEs.
Okay. Right.
That's nice.
Okay, ma'am.
So I think initially, Mr. Navneet, you would have introduced sir. At least many of the participants already must be knowing. And sir is professor and head at JIPMER Pondicherry, in the Department of ENT. And endoscopic ear surgery is one of his passions. So that is why I think the demonstration has been so nice. And okay, so one of the participants is saying that now only I have understood the procedure. I go to the OT to watch cases, but most of the time I'm not able to understand the technique. Yes, sir.
So my aim for this webinar was to at least even 1 or 2% students start doing endoscopic ear surgery. My job will be done.
Yes, sir.
And once COVID is over, we hopefully next year we will be organizing endoscopic ear workshop in our hospital, medical college.
Okay, sir. That's very nice because one participant had asked also that.
We'll organize. Most probably, if pandemic is over and conditions are okay, then next year definitely we'll organize endoscopic ear workshop. Okay, madam.
I think we should close it here. And thank you once again, sir, for the excellent talk.
Thank you.
Thank you, Mr. Navneet.
Thank you very much, Professor Sunil Kumar Saxena, for the presentation. And thank you very much, Dr. Nilima Gupta, for joining us. And thank you, trainees, for joining us.
Thank you. Yeah, you can.